Good morning, everyone. Welcome to today's episode of PYA's Let's Get Rural webinar series. Today's topic is key policy, payment, and program changes shaping rural care in 2026. PYA is happy to present today's webinar on this important topic. With that, I would like to introduce our presenters, Martie Ross and Kathy Reep.
Morning, everyone, and thank you, Jennifer. Looking forward to our conversation today. PYA presents a twice a month webinar series called Healthcare Regulatory Roundup, but we try twice a year to focus in on issues specific to rural providers. And the reason I say we try to do this twice a year is because in 2025, we were scheduled and ready to go in December. And we made the executive decision that let's wait to see what happens with the Rural Health Transformation Program. And let's have this webinar in early January instead. And we're very glad we made that decision because it gives us a lot more stuff to talk about, as well as the fact that we still have Congress somewhat in limbo and the potential impacts of what happens with the once again threatened partial government shutdown to take effect January 30. So we want to highlight some of the issues around rural extenders and telehealth, and we're in a far better position to do that now in January. So, Kathy, I hope that was enough of a rationalization of why we were lazy in December. What do you think?
I think that works. I think it works. It basically says we did not know very much in December about what was going on, and that kind of continues.
Exactly. Well, of course, the big news in rural health right now is the Rural Health Transformation Program. We're going to go a little deeper into this, kind of explain how the program operates, because I think there's a whole lot of misunderstanding at this point in time. The Rural Health Transformation Program, as you may recall, was part of the One Big Beautiful Bill Act. In fact, it was the last piece of the puzzle added at the 11th hour, more closer, to, I guess, to 11:59, in the Senate to secure the last votes to pass that legislation out of the Senate. And it was created, at least initially, the impression was this was created to offset the negative impact on rural hospitals as a result of the Medicaid reductions in spending that are part of OBBBA. And I think that's exactly where the confusion begins, because I think folks equated the Rural Health Transformation Program with the COVID Provider Relief Fund, that these were dollars going to providers to offset losses. That is not the case. The legislative language is very clear. The folks that initially proposed this as for inclusion in the legislation have made it very clear that the purpose of this fund is it's venture capital. It's dollars available through to the states to really facilitate innovation, to transform the delivery of healthcare in rural communities. So it's not a dollar for dollar offset to the lost Medicaid spending. It is instead dollars that are intended to make rural healthcare delivery more efficient, more effective, higher quality, focused in on prevention, and thus reducing costs and hopefully then shoring up rural providers. So it is a grand, let's be honest, it's a grand 5-year experiment that is incredibly well funded, and really is a single largest investment in rural health since the initiation of the Critical Access Hospital Program back in 2001. So what's there? It is a congressionally appropriated and authorized expenditure of $50 billion over 5 years, beginning now in federal fiscal year 2026, continuing through 2030. And actually, it bleeds into 2031 because of how the dollars are spent. That $50 billion is split between what they refer to as baseline funding and workload funding, meaning baseline funding, every state that submitted an application, and all 50 did, received $100 million. So in year one, and that will be the case, presumably year 2, year 3, year 4, year 5. But right now, CMS is focused on this year one funding. So that was the base. The other half of the money, so the other $5 billion for year one, was allocated to workload funding. And the workload funding depended on the state score across certain rural health factors and the quality of its application, as well as a snapshot of current state law. So if you think about it, if you got $100 billion, 25% of that, 2.5 billion, is going to be allocated to the states based on their score on a list of objective rural health factors. And this ranged from everything from percentage of population living in rural areas, number of CCBHCs, number of rural hospitals, down to actual square mileage of a state. So no surprise that Alaska and Texas did well on these particular measures. The other 25% is the competitive component of this program. That is the quality of the application submitted by the state, and how it incorporated the initiatives that were discussed in the Notice of Funding Opportunity. We'll go into detail there in just a second, but as well as certain state policy factors. So a percentage of that 25% was tied to how the state aligns to certain policy priorities identified by the Trump administration. And this ranged from, where is your state on certificate of need legislation? Where is your state on practice at top of license? Are you requiring the presidential fitness test? Are you requiring physicians are required to participate in continuing medical education around nutrition? And as part of the application, the states attested to where they are and where they intend to go on those particular state policy message. But really, this whole key component of the application that was submitted by each state was what is referred to as their Rural Health Transformation Plan, which is how they intend to implement the initiatives specified in the Notice of Funding Opportunity. Every state was told to build a plan and submit a budget based on receiving $200 million each year. So submit a 5-year budget at $200 million each year. And you were restricted to only expend 10% of that total budget on administrative costs. So the state could not say, hey, we're going to keep out of that 200 million, we're going to keep 30 million. In fact, instead they were limited to 20 million for administrative costs, actually administering the program in their state. There were other restrictions on types of funding: no construction, no purchase of food, no payment for services that are currently reimbursable by insurance. And so the states had to navigate those restrictions as well. Sort of a kick to this program, because it's over 5 years, there's a temptation, as there are in many grant programs, to sort of muddle through and get a no-cost extension. So expend the money after the actual term of the grant program. But in this case, CMS requires a state to obligate funds by the end of the budget period, and then to have expended all funds by the last day of the federal fiscal year following the award of funds. So in the case of year one, that means that all funds that a state receives have to be obligated by October 30 of 2026. And then they're going to have to be expended by October 30 of 2027. So effectively no carryover. And as I said in the NOFO, if we have states that don't use it, they lose it. And those funds then become available actually for distribution among the other states. So the rich get richer, the poor get poorer, shall we say, in terms of these distribution of funds by the federal government. So that's the background. What happens next? But first,
and Martie, just clarify, it is federal fiscal year that the funds have to be expended by. It is not the state's fiscal year.
Exactly. And that, of course, is confusing, because we all know federal fiscal year 2026 started October 1, 2025, but the notification of awards were not released until December 29th. And as we'll discuss, the actual release of funds is still at a date to be determined. Again, highlighting here an informational bulletin that went out in early December from the Center for Medicaid and CHIP, regarding implementation of the work requirement, or this they refer it's community engagement. It's generally referred to as work requirement. because you can satisfy the requirement by engaging in community-based activities, but generally the term of art we frequently use is work requirements. So keep in mind that we're going to be implementing the work requirements through 2026, figuring out how to do it, because they go into effect January 1st of 2027. Now, a state can request an extension if they're demonstrating progress in their implementation, but that's only for 2 additional years. So again, this is the example of the loss of Medicaid funding, because if you have a work requirement, it is anticipated that's going to reduce the number of individuals that come to your facility that are covered by Medicaid, and thus increasing your uncompensated care. And that is exactly where we saw this tension with OBBBA, is because you're going to see that loss of revenue to rural facilities. But again, just to highlight one more time, this wasn't intended to be a replacement for those dollars. I mean, the fact that states were treated the same, regardless whether they were expansion states or non-expansion states, indicates right there that this is not intended to solve the problem of lost revenue to the states because of Medicaid reductions. But again, it's just something to keep your eye on this year, is how your state intends to move forward with the implementation of community engagement / work requirements, because certainly that's going to impact all providers as they either treat individuals who have previously been covered by Medicaid, or how they help patients qualify for Medicaid that come to their facilities.
But again, going back into the expansion versus non-expansion states, that work requirement, the community service, is not applicable in non-expansion states.
Exactly. So because it's targeted to the expansion population.
Expansion population, right.
Exactly. So here in Kansas, there in Florida, Kathy, we can just wave and watch it go by. Exactly.
Unless we have governors who decide to implement a work requirement.
They're on their own. That's true. True. Yes, the state can elect to do that even if for their non-expansion population.
Right.
Even though, of course, non-expansion populations are pretty narrow. Most qualify because of a specific category, such as traumatic brain injury or SMI, whatever it may be. But okay, more on Medicaid than you ever wanted to talk about. Back to how CMS determined the awards to the states. Again, remember, 100 million of it is set because you are a state in the union. You got a star on the flag. The other portion of this, again, as we referenced, the score was based on 23 separate factors that were specified in the Notice of Funding Opportunity that was released on September 15th. And again, there's those objective criteria, kind of the in-between state policy factors, and then the initiative-based factor. Each factor is assigned 100 points, and the state score for the budget period is the weighted sum of their score on each of those factors. Now that CMS has calculated the rural facility and population score, those objective measures, they're not going to recalculate that. So if you are a state that annexes another state, it's not going to do any good. It's not going to increase your square mileage, because CMS is going to continue to use its calculation made back in December of the state score on those objective rurality factors, as we call it. Did you know there's a word called rurality? It's a real word, Kathy, and I have a lot of trouble saying it. But
I have started seeing that in more and more articles, the rurality versus urban.
Yes, rurality versus urban. Here is the summary of these objective factors. And again, score on these have been calculated and it will not change. And remember, there's very specific language in the statute that say you cannot appeal the secretary's decision. So if you think that it accurately reflected your total square miles, there we go. You keep going back to that one because it's easy to get your head around. You can't appeal it. It's just CMS has made its decision and it is what it is. And so those are the scores we have on those factors. I just want to talk about the policy factors. I made reference quickly to them before. On the next 2 slides, we've listed out the 8 policy factors, and you really get a feeling of how broad these really are. And it's everything, again, from reestablishment of the presidential fitness test. Remember, President Biden abolished the fitness test. President Trump has now brought it back by executive order. The SNAP waivers is whether the state has requested the USDA allow a waiver that prohibits the purchase of non-nutritious items through through SNAP. So states, there's an incentive there for states to pursue those waivers. The score for a state varied on whether you've not even submitted an application, you've submitted but no action has been taken, and you've actually received the waiver. So it's sort of weighted across those. As an example of how a state could improve its score over time by, again, pursuing that and receiving the waiver. The nutrition, continuing education, again, requiring that physicians annually engage in some CME around nutrition. I've referenced previously the certificate of need. But once it's great to be in a state that has zero certificate of need statutes, because we scored higher as a result of that here in Kansas. Licensure compacts. Is your state participating in the different licensure compacts that allow a doc in one state to practice in another without having to go through full credentialing in both states? Scope of practice is referenced previously. What can physician assistants do? What can nurse practitioners do in your state? What can dental hygienists do in your state? Short-term limited duration insurance. Does the state restrict these policies beyond the latest federal guidance? And finally, remote care services is looking at your Medicaid program in your state and whether it's reimbursing for different types of remote care. So those were scored based in part on information submitted by the states, based in part on data sources identified by the federal government. And these will change as states change their policies. We'll go on then to the initiative-based factors. So this is truly how does a state intend to implement its rural health transformation plan? So again, this is going to weigh out to about 35% of the dollars that the state received, but it's actually more important because yes, it impacts your score, but these initiatives drove what your plan looked like because you had to hit the initiatives in describing what interventions the state intends to pursue with the dollars that it receives. So yes, you're going to get $200 million. Your score is going to be 35% dependent on the initiatives that you present, but you could only spend the $200 million on the initiatives that you included in your plan. CMS has indicated there's some leeway there. You can make some variation from the application you submitted, but it is going to have to be specifically approved from CMS because at this point in their notices of award, CMS has identified which are the allowable initiatives for each state. So just again, to review these so you're aware of I don't want to say constraints, but at least the structure in which your state was operating as it developed the RHTP plan that it's now going to implement. So you start with a population health clinical infrastructure. How are you going to coordinate services among providers? How are you going to strengthen the rural health ecosystem by focusing on primary care and access to specialty care? Health and lifestyle are really the prevention component of the state's plan. What are going to be the novel prevention-focused interventions? How are you going to promote lifestyle changes, nutrition, and exercise within your population? And how do you engage beyond just the traditional rural provider community, but reach out into communities with this? Rural provider strategic partnerships. So how can we best have collaboration and coordination across the continuum of care? How you develop those relationships, how you reinforce them with remote care services, for example. How do you expand access to specialty care services and secure that access within those rural communities? They also address here right-sizing hospitals, which they refer to, that's kind of the push towards rural emergency hospital status as appropriate for hospitals in rural communities. Initiative number 4 was EMS, really a question of how are you going to address transportation issues? Because of course, you can't have a continuum of care unless you have the ability to transport patients appropriately across that continuum of care. And so that was one of the factors to be addressed in your plan. Talent recruitment, this is the workforce component. And again, this is K through 12 all the way up to rural residency programs and how you intend to reinforce that with dollars through the program. Note here, the requirement that CMS had to follow because it was actually in the statute is that to the extent you are funding programs to train individuals to hold positions in rural areas, those dollars come with a 5-year commitment from that individual who accepts those dollars to remain in practice in a rural area. And there is some question here still remaining. CMS needs to clarify, if I'm doing a very basic training program, if I'm helping an individual become a community health worker, is that the same in terms of their obligation to remain in practice for 5 years in a rural community as, funding a rural residency program or providing bridging dollars to a physician who elects to practice in a rural community? So I think we'll need some clarification there on that 5-year requirement, but certainly at the higher end of that spectrum, right? Funding residencies, funding incentive program payments, those are going to come with 5-year commitments. Medicaid provider incentives. So this is requiring the state to implement some sort of value-based program within its own Medicaid program. So partnership with the MCOs, partnership with providers to create these opportunities. Number 7 is dual eligible enrollment in integrated plans. I mean, again, talk about wanting to move the needle on specific issues by tying funding to what the administration wants to accomplish. This is the appreciation that the most expensive people in healthcare are individuals who are dually eligible for Medicaid and Medicare. They outsize the percentage of the total spend as compared to others in the population. So we're looking for opportunities to move that population into integrated plans. So specifically the DSNP plans, PACE programs, and the like. So how is your state going to incentivize that? And if any of you have worked in rural PACE, it's really hard figuring out how to take the program requirements and implement them in a rural space. Hopefully we will see some flexibility out of CMS around PACE programs as well as state agencies that operate those programs in partnership with CMS. Number 8 is remote care services, enhancing your infrastructure to deliver services remotely. Data infrastructure, the broader investment in EHR, clinical support decision tools, heavy emphasis here on effective use of artificial intelligence in the delivery of healthcare, as well as just improving interoperability and aligning with that CMS health technology ecosystem criteria that really find more and more providers committing to that ecosystem. And finally, last but certainly not least, consumer-facing technology. How can we better serve rural patients by, again, leveraging emerging technologies so that these are tools that can help them manage a chronic condition to engage in healthier lifestyles? And how are we going to, again, push those out into rural communities through provider relationships, through community organizations? So that's what your states were doing, was trying to write a plan that hit across all of those initiatives. At the same time, as I referenced previously, there were a number of funding restrictions that states had to adhere to as well, starting with that administrative cap at 10%, the restriction on indirect costs on any program at 10%, limiting the amount in capital expenditures and infrastructure at 20%, again, not being able to pay for services that are currently reimbursable. You cannot pay, this is sort of an interesting one, you can't pay for a clinician's salary or wage support if the institution imposes non-competes on clinicians. So again, those are these commitments that had to be made by the state as part of it. So with all of that, the state submitted their applications, their plans were limited to 60 pages and a 20-page budget narrative to explain how you were going to do all of this and spend your $200 million. I've had greater flexibility, Kathy, in writing a $2 million grant than one that's 100 times that size. But that's what the complexity and the efficiency with you had to deliver your plan in your state. But every state submitted an application by November 4. CMS told us over and over and over and over again that they would make the announcements by December 31st. We got our present, either we got our Christmas present late or our resolution for the new year early. But on December 29th, the Monday after Christmas, CMS released the funding awards, or they released the notice of awards to each state, and in that notice of award indicated which of the state's initiatives proposed in their plan would be allowable. So this is the time frame under which now states are operating in this program. Again, the award dollars came out. There was probably, I think, less variation from number 1 to number 50 than we anticipated. Texas got the most money at $281.3 million. New Jersey got the least, give it at $147.3 million. Given the fact there's not a rural hospital in New Jersey, it's a pretty good deal, I think, for them. But that's how the funding was awarded, and they're sort of all the way down the line, 50 states, and it roughly, I don't think it's exactly 25 below 200 billion, 25 above, but it's close. It's very
But
close.
Martie, as a question, okay, New Jersey doesn't have any rural hospitals. Okay, they've got $147 million a year. If they can't expend it,
Oh, great question. If they
it's
remember,
going to wind up going to being redistributed, correct?
yeah, exactly. I mean, they have until October 30 to obligate the money, saying we're going to spend it on this, and we have a signed contract, all of that, right? And then they have to expend it by the following.
And that's the 147 million, but then they've got to do it again each year over the 5 years.
Exactly. But if they don't expend, if they don't obligate, any money that remains unobligated goes back into the pool. So CMS can award those dollars to a different state. Now, it's only impacting the 47.3, right? The 100 million is guaranteed to all states across. As I understand it, actually, that's an open question.
In the 47.3 and it gets reallocated, do they get the 47.3 the next year that they have to try and spend again? Or have they been permanently reduced?
Again, it's a question of how you read the NOFO. And understandably, I'm giving CMS all the credit in the world because they stood up this program incredibly fast on a very lean staff in the middle of a government shutdown. But you can read the NOFO both ways, that your performance is going to be determinative of your following year award. I don't know if that includes your ability to actually obligate and expend the funds.
Okay.
Or simply your ability to hit milestones. So you can read it. I read it both ways. I think that's a question to CMS. Okay. So every state now has to submit a revised budget to CMS by January 30. So, in states that receive more than 200 million, you got to figure out how you're going to expend that additional dollars. Okay? What programs are going to get more money? What are you going to modify programs? However you're going to do it. The key here, and what you're learning from the project officers, is the state talk to the project officers. This is your opportunity to provide the level of detail that will be sufficient for CMS to release the funds. Again, the fact that the initiative is allowable does not mean CMS is going to release the funds for that initiative. Now it's up to the states to go to the level of detail that you would traditionally see in a grant. And the examples these offices are giving, like, what's your, ink budget going to be across these years? And if you're doing travel, who's traveling and where are they staying? So they're talking about a significant level of detail across these plans. And remember, states developed these plans in 6 weeks. So it was very fast. Budgets were very broad in terms we're going to spend 100 million here, 100 billion there. And now the focus is in this very short period of time to produce a very detailed budget so they can start drawing down the dollars. And here's where the frustration begins, because CMS has a lean staff at this point. They're still training up new staff, and how they promise they'll do better than the usual 45-day turnaround. But we're going to see some frustration as states want to launch, but without the assurance at the state that they're going to be able to use funds from RHTP for that program. Are they willing to risk it and front the money? So that's going to be a very interesting period of time here in Q1 of these awards. Why that's critical, and so then we assume that in Q1, at some point in Q1, dollars will begin to be available to the states to implement programs. A lot of states right now are really struggling with procurement law. But their state restricts how they can spend dollars received through a federal grant. Do they have to go through the full procurement process? Does the legislature, in fact, have to step in and do a release of funds? Because in some states they have expenditures structured in such a manner. So all of that is sort of in play right now as well. Again, into the first reporting period for a state is July 31st, because then on August 30, each state is going to have to produce an annual report indicating its progress on milestones And that is accompanied with the state's request for funding in the second budget year. Don't know exactly what that's going to look like, but again, the clear indication from CMS has been your future funding is going to be tied on satisfactory progress on work plan implementation. So there is a lot of pressure on the states to produce and produce quickly, and there's going to be, I would assume from most states, a call to the provider community to be their partner to get these programs stood up, to get these funds obligated, because again, first budget period ends October 30. That's when you have to have all funds obligated. By October 31st is when we're going to hear each state's going to get a phone call, well, going to receive a message saying, here's what you get for year 2. But they're still expending the funds from year 1, and they have to accomplish that by September 30. So all the receipts have to be in the file by September 30. Any monies that remain are going to be, again, clawed back by the federal government. Yikes, right? Just yikes. Not to raise a concern, but we're going to raise a concern here, is that a question I heard asked repeatedly by providers is, could this money go away? Because we've seen the administration pull back dollars that have been appropriated previously by the federal government. The answer that CMS has been giving to that question is that these dollars have been authorized and appropriated by Congress. They are not impacted by any government shutdown. So if the government does shut down on January 30, we'll talk about that soon, that's not going to impact the administration of this program. That's what they promised. The reason we had a particular concern yesterday was the announcement that came out of the Trump administration that they were rescinding about $1.9 billion in grants that had gone through SAMHSA that were focused on addiction and mental health. And literally providers throughout every state were going, wait, this is shutting our program down. And no warning, just receiving the letter on January 30. The headline this morning is that the administration has reversed course on this and that they will not see these reductions. So is the worst of times the best of times. It's very, very much a roller coaster for organizations that rely on this funding from SAMHSA. That they were out, and now it appears those monies are again secured. But there is always that concern we would see similar mischief in our HTP. And given that this was a key component of the One Big Beautiful Bill Act, given there is bipartisan support for this, I mean, there ain't a congressman that doesn't have a rural community in their district. Maybe there are a few, right? I shouldn't say that so quickly, but there's definitely political will around rural issues. So we hope that is the case, but it's just the insecurity we deal with in terms of potential funding shifts. But if I had to pick a program where I felt safe, I think I'd feel pretty safe in our HTP. With that, oh my God, I've gandered on for over half an hour about this, Kathy. I apologize, but let's go to one of our attendance polls. So Jennifer, over to you.
All right, our first question is, do you expect Rural Health Transformation Program funds to benefit your organization? Yes, no, or unsure?
Kathy, most states have posted their applications, not all, but at least most have had summaries, and I really encourage folks to take a gander at their state's plan, ask questions about the plan, figure out and identify those opportunities. We know there are a lot of hospital associations that are looking at their state plan, trying to figure out how they can help their hospitals secure funding under those plans. So it's definitely, they ain't necessarily going to come knocking on your door with a check. But it's not the provider relief fund, but it's where you're going to need to engage to be part of the process.
Right. It's not, now we're going to take all this money and send it to the hospitals. It's going to be, we're going to have to work for it. We're going to have to put programs in place.
And that's an education session for state legislators. As many state legislatures resumed this week, back in session, they're kind of going, well, where's the check to my hospital, the hospital in my district? And it's like, got to explain, hey, that isn't what this program's about. And we're doing, the administration is doing their best to allocate the dollars previously. Here in Kansas, we have that wonderful split of a Republican supermajority in the legislature and a Democratic governor. And again, these monies went to the governor. That's the recipient of these dollars. So there's some tension there that that folks are navigating with those legislators that want to be part of the process. So Are these the results? Are we done?
Before you go to the results, I would just also comment, as you said, many state legislatures are now in session. We don't want to see states say, well, you've got all this money, we're going to cut this state program. You need to make sure that you are educating folks within your state and federal delegation to understand that this is not money coming directly. It's just a long process, and that cutting your current programs just won't work.
No, because it's again, one of those explicit statements that CMS has made is you can't use this money to replace a state expenditure. Exactly. So you can't say, oh, we've had this really groovy program to support FQHCs in our state, but here's our opportunity to cut that, help our budget, and instead use the RHTP funds. You cannot do that. You can expand a program, but you can't replace current spending with our RHTP funds. Ugh. Trust me, it's a full-time job keeping all these requirements straight.
So survey results.
Okay, survey results. Looks like half of you have faith that this is going to improve your world. Glad to see it. About 40% of you are waiting, and others, and I assume maybe you're not rural facilities, are about 12% of you are saying we don't think this is going to help us at all. Okay, moving on from that, let's completely change gears. Wow.
Let's go and take a look at what Congress is doing or not. But I think if you listen to some of our webinars towards the end of last year, we were looking at, I guess this would have been the legislation that came about in November related to the continuing resolution. You know, government shutdown the beginning of October for a period of time. I think it was the longest shutdown in history so far. And so that we did wind up reopening the government with a continuing resolution that pushed things further down the road, but only to January 30th, not even January 31st, but January 30th. So, you know, if you look at your calendar, that is 15 days away. And what do we have in terms of moving forward with the continuing resolution? Not a whole lot. The issues that we are looking at that Congress needs to address is, and Martie's going to talk about telehealth shortly, but the telehealth flexibilities that came about under the COVID waivers, do we keep those? Where are they going? Are we pushing it further down the road? Are they going to have how are they going to deal with this? The issue of community health center funding, the rural floor as it relates to the geographic practice cost indices, the rural ambulance add-on, the payments for low volume and Medicare dependent hospitals. We're getting back to where we were on October 1 in terms of the future of these programs and whether or not they're going to continue and how they're going to be funded. I have not seen a lot of action in terms of ongoing negotiations as it relates to legislation to go into place to stop another shutdown by January 30th. I do know that they are looking to vote on a labor, health, and human services a budget sometime next week. The question is, what will it do? And what provisions could be included in that legislation? And recognize also that any legislation is going to require a majority vote in the House and a full 60 votes in the Senate.
Yeah, the good news, Kathy, I guess it's always hard to find good news around this, right? But was it 35 days? Was the last shutdown 35 days? Yeah. It appears that the Medicare claims were all eventually paid appropriately.
Yes.
There's not been stories of, oh my gosh.
Yeah. Paid back. But it was that issue again. I'm going to use telehealth because I know you're going to talk about that in a minute. Are we scheduling some of the telehealth services into February, March that are appropriate now, but might not be absent the continuation of the waiver or program being made permanent? So concern there. While we talk about the issue of Congress needing to act, we also have that issue of the enhanced premium tax credits going on between the House and the Senate. We do know that we have a bill that was approved in the House that would extend those premium tax credits for 3 years. They're talking about it in the Senate, but we don't know what we're going to get. And we also don't know if we're going to wind up with approval by the president. Remember, he's going to have to sign anything that is done. When we look at the issue of those enhanced premium tax credits, report did come out yesterday related to the, actually it came out on Monday, the enrollment. Under the exchange, the enrollment, we've seen about a 3.4% decline over 2025, reduction in the number of people. What does it mean? Obviously, these are people who might no longer have coverage, or if they have opted in, they could be looking at a bronze plan or a high deductible plan. How does this impact your ED and your volume of uncompensated care payments? And I really think you need to take a look at that from your state perspective.
And wait a second. I mean, I'm sorry, Kathy. I don't know you, but I would do that all the time. That 3.5% is misleading. That's people that have enrolled. That is not people who have made the first month's payment.
That's true. That's enrollment only. And
so that's the number.
We don't know what they've enrolled in. So if those who have enrolled are in plans that are extremely high deductibles, do they have the dollars to pay what they're going to have to pay out of pocket to receive services?
So it's both. It's when they see that first monthly premium invoice and they go, oh, I'm not paying that. I can't afford that. Or it's like, oh, wow, my out of pocket just went through the roof. What do I do now? So this is going to be, I was with you, Kathy. I was watching those enrollment numbers and it was 3.5. I'm like, that's not, I thought it'd be more than that, but then it dawned on me.
They haven't paid.
Do they pay? Yeah. So don't take any comfort in that 3.5.
We're going to check. We got to check those numbers again in a month.
Yeah, today's the last day. Today's the very last day.
Today's the last day. If you enroll today, your coverage would start in February.
And did my son wait till December 15th to enroll? Yes, he did. Yes, he did. So, and did he complain about? Yeah, of course he did.
Do I ask, did he make his first premium payment? No, I won't do that.
He did. He did because his mother would have killed. Okay. Anyway, he wouldn't have needed health insurance is all I have to say if he had not. Exactly. Anyway, and not all 27-year-olds have a mom like me, right, that are going to be riding them roughshod. And so again, when they get that first invoice check, it's going to be rough. Okay. Status of Medicare telehealth coverage. Yikes. It seems like this is the same story, different day, but let's walk through where we are with the January 30 cliff. Let's start with telebehavioral health because that's where we have some amount of stability. Because way back during the COVID era, Congress made permanent coverage for telebehavioral health services that are furnished to a beneficiary in their home, regardless of whether they're in a rural or urban area. And they also permitted that those services be billed by physicians, practitioners, as well as rural health clinics and FQHCs. Because remember, pre-COVID, RHCs and FQHCs couldn't bill for telehealth services that they delivered. But it could be an originating site, but not a distant site that could bill for the services. However, there were conditions in that legislation on initiating telebehavioral health services that have been waived up to this point in time and would become effective absent congressional action on January 31. And that means initiating services. Services may only be initiated within 6 months of there being a face-to-face visit. That face-to-face initiation requirement has been waived. And in fact, it will, for any patient you've started seeing providing telebehavioral health services prior to January 1, you would not have to have a face-to-face visit. They made that clear. But going forward, new patient have to have a face-to-face visit within 6 months prior to initiation. And then on an ongoing annual basis, there needs to be a face-to-face visit. But there are exceptions there, and they're pretty broad exceptions. You can drive a truck through them. That effectively, if you doc can attest, the practitioner can attest to say it would not be appropriate to see this patient face to face. And so But those exceptions do not apply to the initial visit. So that's one thing we watch carefully is what will happen there. Regarding medical telehealth services, we go back to the draconian pre-COVID rule that you could only receive reimbursement for telehealth services if the patient is physically present at a facility that is located in a rural area at the time of service. So no more services in the home and no services in urban areas on medical telehealth services. Also, we will revert back to the rule that physical therapists, occupational therapists, speech language pathologists will be unable to bill for Medicare telehealth services. Again, that's a COVID advancement, allowing the therapists to provide services via telehealth. If absent, again, another extension, they're not going to be able to bill for those services going forward. Through January 30th, so current state, those medical telehealth services that CMS previously identified as being covered audio only will continue to be covered audio only. But going forward, a service will be covered audio only if the beneficiary is at home when the service is provided. That's kind of a problem, right? The practitioner is capable of an audio-visual connectivity, but the beneficiary cannot or does not want to use video. So it's really, as you see, targeted in on telebehavioral health services, because those can be delivered to a person when they are in their home. But if you have sort of the patient coming to the facility to receive telehealth services, it's got to be audio-visual. Audio is not going to be enough, again, unless those rules are changed by Congress when they hopefully resolve the partial shutdown. What we also need to talk about changes that were made in the 2026 Medicare physician fee schedule that impact telehealth services. That includes a streamlined review process for what will be designated a telehealth service. As you recall, if you go back to February 2020, it was a very narrow list of the type of services that could be delivered via telehealth. That list expanded significantly during COVID. CMS decided to include all of those COVID-era services as telehealth services, and now they're providing a much streamlined process to add new services to the list. And in fact, you'll see for 2026, the new services that will be included in coverage for telehealth services. We'll go into detail there. The other big victory in the 2026 physician fee schedule is the removal of the frequency limitations for delivery of certain services via telehealth, specifically subsequent inpatient visits, subsequent nursing facility visits, and critical care consults. So it used to be that only so many times a day you could provide a service via telehealth. The others had to be in person. We've wiped that out. So these services now can be provided exclusively via telehealth. I'm kicking after you, Kathy. Excuse me.
Sorry, it must be catching from Florida to Kansas.
That's kind of hard, but it probably would work. The other good news was the expansion of virtual direct supervision. Again, COVID era allowance that you could provide direct supervision virtually, right? Use our cute little Android or Apple phone to accomplish virtual supervision. They have now made it permanent. Yay! That's going to impact Incident 2 services, diagnostic tests that require direct supervision, as well as pulmonary rehab, cardiac rehab, and intensive cardiac rehab. And then again, certain hospital outpatient services, you can look to the specific provision. What's not included are the services that are part of that have a global surgery indicator of 10 or 90. Those will continue to require a real live in the flesh supervising practitioner. So good news there, finally. Telehealth for RHCs and FQHCs specifically. Reminder once again that CMS is permanently allowing FQHCs and RHCs to provide telehealth visits, telebehavioral health services via telehealth. So again, those in-person eligibility requirements will apply, but the good news is that CMS delayed those through the end of 2025 for RHCs and FQHCs. Confusing as heck, right? For everybody else, that's dependent on Congress taking action, the continued waiver of those in-person requirements. CMS, because it's expanding the scope of RHC and FQHC services to include telebehavioral health services, has said, no, we'll continue to waive those requirements through the end of 2025. So if Congress doesn't act and we're on May 1st, and you haven't seen that patient face-to-face, you could still initiate telebehavioral services in the RHC or FQHC, because those in-person requirements are not going to apply in that particular category until January 1st, 2026. And of course, we will see what happens next with current other waivers. There's also a 1-year extension to bill for non-telebehavioral health visits, including audio only. But remember, and you'll use G2025, but you are still going to have to meet the requirements for delivering a service via telehealth. CMS still wants to go back to including G2025 in PPS and error rates instead, so that would be a higher reimbursement for telehealth services. Certainly something we want to push in 2026 because, of course, that reimbursement under G2025 is lower than your error rate. You're delivering a service, and in other instances, CMS doesn't distinguish the reimbursement of telehealth versus non-telehealth. It does in this particular instance with RHCs and FQHCs, and so that is an important advocacy piece coming up in the rule for 2026. So when that proposed fee schedule comes out in July, be ready to comment on that particular issue. And finally, enrollment issues have continued. We have had CMS has waived the requirement to include a practitioner's home address if they are delivering services from their home. They did not extend that. So now if you're enrolling a practitioner and a location of service is their home because they are delivering a substantial portion of services, not just a 1Z, 2Z, but a substantial portion of services via telehealth from their home, you would have to enroll and list the physician's address. You see, though, however, that they have provided some guidance on suppression of the street address to protect the privacy of physicians. And so if you are in that position, be sure that you're reading that guidance carefully. Guess what, Jennifer? You're back up with question number 2.
All right. Our second question is, what do you think Congress will do regarding Medicare telehealth coverage by January 30th? Nothing. We're headed for another partial government shutdown. No shutdown, but coverage will not be extended. We'll approve coverage extension through the end of fiscal year 2026. We'll approve coverage extension beyond fiscal year 2026. Remember.
Okay, we good?
Okay, thank you for participating in our poll. Back to the presenters.
Very interesting.
Yeah, all over the map. I say they're going to extend it through FY 26. That's my guess. What do you say, Kathy?
I kind of am going with we're in for another shutdown.
You are not. Pessimist you.
I'm sorry. I'm sorry.
The fee schedule also had other changes. A 2026 Medicare physician fee schedule is where we see changes to billing for RHCs and FQHCs, even though they don't bill on the physician fee schedule for all services, but neither here nor there. This is this whole change that started back in 2025 of how RHCs and FQHCs bill for care management services, because previously you had one code that you billed all the services for, regardless of the amount of time delivering the service. That has changed now. The direction to RHCs and FQHCs is to bill for the code, the specific code, the 99490 for chronic care management services, for example, and you'll be paid at the national non-facility rate. So when CMS is making changes to its suite of care management services, you start having to pay attention because they now impact you. And that includes advanced primary care management services. This was new service entered, this new code reimbursement introduced last year. It doesn't require recording minutes. It's instead really based on the severity of your patient population. What they did this year is an add-on to APCM to include behavioral health integration. So if you're doing APCM, you now have this opportunity to also provide behavioral health integration services and receive additional reimbursement for those services. Note that these services can be delivered by the RHC or FQHC practitioner directly, or it can be provided by clinical staff under their supervision. And if you're going to go this route, remember, you have to have separate consent both for APCM as well as BHI. You see here how CMS has created these BHI add-on codes for APCM. They're tied, they are aligned to the current codes for separate delivery of these services, but we are eliminating the time requirement for the services going forward. And then you see the valuation of the codes, the potential reimbursement to the organizations. You'll be, again, for RHCs and FQHCs, you're at that 2026 national fee schedule price. So the higher reimbursement if you add, providing that BHI service as well as the APCM. And again, looked at a lot of states, RHT plan applications. There was a lot of money going into helping rural providers launch behavioral health integration services. So again, look for that opportunity in your state. Also, changes that were made to reimbursement for remote physiological monitoring. Again, RHCs, FQHCs bill for these using the CPT codes and are again reimbursed the national non-facility rate. What we added this year is new codes for shorter periods of monitoring. So previously you had to have at least 16 days of data to bill for these codes. We've now allowed billing for services for monitoring that goes from 2 to 15 days. So it's a lower reimbursement. Interestingly, the reimbursement is not simply 50% of the existing code, but instead it is based on a conversion from OPPS, which is kind of CMS trying to reweight these types of services that both can be delivered in a physician clinic as well as in a hospital, and beginning to use OPPS data to set those rates. And so again, it's a much broader initiative by CMS to start changing the way it sets rates for certain types of services. In addition to monitoring for lesser periods of time, we're also going to be able to bill for that treatment management services, and now having a code that allows you to bill for that for the first 10 minutes. So not having to spend that whole 20 minutes to reimburse, you can now receive a lower reimbursement for 10 minutes. What's interesting is they didn't do this for chronic care management. It's only for treatment management services. So we don't have that lower code available for chronic care management services. Similar action CMS took with respect to the remote therapeutic monitoring codes, but we continue to have that contractor priced for cognitive behavioral therapy. Again, trying to really expand the availability of behavioral health services in rural communities. These cognitive behavioral therapy tools certainly open up that opportunity, but obviously hesitancy to go into that when you're contractor priced and not really having the security. Additional, they also made the change in RTM that allows treatment management services to be at 10 minutes as opposed to 20. For other care management services, CMS is finally letting go of G0512 for the more complex version of behavioral health integration, the care management, comprehensive care management service, comprehensive behavioral health services. And you see that now we'll bill for those as opposed to G0512, which of course means better reimbursement for these services for RHCs and FQHCs. CMS is getting rid of G0071, which have been the codes you've billed for communication technology-based services. Instead, now that you are going to bill for the individual CPT codes that had rolled up into G071, excuse me. So now you're going to be billing for 2010, 2250, as well as 98016. Again, good news, because in most instances, the fee schedule reimbursement is going to be higher than the reimbursement you've previously been receiving under G0071. That runs the gamut, right? So CMS has now effectively eliminated the special codes for RHCs and FQHCs in the delivery of care management services. They're effectively on equal footing with physician fee schedule reimbursement. One change to take note of is CMS restructuring reimbursement for social determinants of health SDOH screenings. This had previously been the use of a tool to screen across multiple conditions, multiple social determinants. We are now no longer using the term SDOH. We're using the term upstream drivers by the administration. And now this code is limited to assessing physical activity and nutrition. So we're not looking at housing, we're not looking at transportation. Now you're going to be reimbursed for using a tool that screens for nutrition and for physical activity. And remember, this is still considered content of an RHC or FQHC service, and thus there is no separate reimbursement for your RHCs and FQHCs under GO 136. So you're not losing anything. It's everyone else that was billing for this. It's now being brought down to much more narrow screening tools. Kathy, talk 340B to me.
I actually going to talk 340B with a focus on all kinds of drug things. So let's kind of look, first of all, at the news related to the rebate program. This was a pilot program that was being implemented. A considerable concern about the program. Basically, rather than you getting a discount when you purchased a drug, it would be a post-purchase rebate. That was not something that was appreciated by the 340B providers. The program was expected to begin in January, but a number of providers stepped in, and they were successful in terms of a judge in Maine issuing a preliminary injunction stopping the program while the litigation related to the actual appropriateness of the rebate program continues. So the litigation would continue, but they could not actually move forward with implementing the rebate program. This would apply across the country. It's not, even though it was a judge in Maine who issued that preliminary injunction, it applies to all. The court did find that HRSA had failed to adequately consider the long-standing reliance of the current program using upfront discounts, nor did they address the financial and administrative burdens associated with the new program. Based upon recent articles, it does appear that the administration is signaling that they might back off and drop their appeal on this particular issue. So we just need to monitor and see what happens next. Along the issue of 340B, you probably remember that a few years ago, hospitals were reimbursed for 340B drugs provided under the outpatient prospective payment system at average sales price minus 22.5 rather than average sales price plus 6%. So this was a reduction in the payment to the providers. CMS had implemented it. Number of providers went to court. Providers were successful, basically with the court saying that there was no basis for that minus 22.5. There was nothing to support that. And that absent a survey, they could not impose just this blanket requirement. So there was a requirement in April that CMS begin a survey. This was an executive order that came out in April. Under the proposed outpatient rule and the final rule, they have implemented what is called the Medicare Outpatient Drug Acquisition Cost Survey, or ODACS. And CMS is required now to survey the acquisition costs for each separately payable drug acquired by all hospitals that are paid under the outpatient prospective payment system. Critical access hospital, you're not completing this, but the rural hospitals that are paid under outpatient PPS, you would be completing this. There was a registration portal that opened in December, basically December 9th through the 31st. Providers were to identify a point of contact and a submitter. That could be the same person, but you started out with a contact. The portal for submitting the actual acquisition costs is now open, and it will close basically midnight or 11:59 p.m. Eastern Standard Time on March 31st. If you go into the website associated with the drug survey, you will see an Excel spreadsheet that lists all of the drugs that they are looking for you to report on. And you're reporting on the period from July of 24 through June 30th of 25 for your acquisition costs. The intent is to use this information for the outpatient rule for 2027, which we would expect to see late July, early August, with the final rule in November. In terms of the information that you are reporting, you're going to be reporting your your net acquisition costs for the drugs that are listed. Those would be inclusive of all discounts and rebates at the national drug code level. However, if you received a rebate or a concession in pricing through a group purchasing organization or something like that, that is separately reportable. There's a separate tab on the reporting in the portal for reporting those discounts. For each national drug code that you're reporting, you're going to report the number of units that were purchased, non-340B and 340B, and your net acquisition cost, 340B, non-340B. Now, the reason I wanted to raise this is because there has been a lot of discussion about whether or not you need to report on this survey. CMS has, in most of their communications, used the words hospitals are to complete. However, they cannot force you to complete the survey. But therefore, they're using the words they are to complete. But again, is this a requirement of law? I don't know when you look at the fact that we have an executive order, but the executive order says that CMS is to develop a survey, doesn't say anything about completing the survey. So can CMS say you have to? They have said in their FAQs that they would consider non-responses and future rate reductions. In the FAQ, they specifically said they are considering the assumptions that would be reasonable to make in the event a hospital does not adhere to the statute, including how those assumptions might be reflected in that hospital's future payment rates. That hospital's not looking at a response of no response lowers the rate to zero, but how it would impact that particular hospital. The final rule itself says that there could be other resources that they use, such as the lowest reported acquisition cost for similar hospitals, prices under the federal supply schedule, 340B ceiling prices, etc. But the one area that I am most concerned about is what I have in bold on the slide, and that is that CMS said we could look for non-responders in terms of not paying them separately for these 340B acquired drugs on which they did not report on, but actually just packaging the drug costs in with the APC for the service delivered. That would be a significant financial hit for those providers who did not report. So I really think you need to be looking at this with a compliance legal perspective in terms of the hospitals are to report per CMS, although they can't force you to complete, but what actions they might take if you don't complete the survey. So again, evaluation internally that needs to happen on this particular issue. Jennifer.
All right. So our third question is, has your hospital registered a point of contact and submitted for the ODAC survey? Yes, no, I don't know, or my organization is not a PPS hospital.
Again, just emphasize that point. Critical access hospitals, not part of this.
Right.
Not being surveyed. Rural emergency hospitals, you're not part of 340B. So certainly you would not be responding. And that's part of the problem with REH, but that's another topic.
I know what the answer would be if that were a polling question. Should they be allowed to?
Exactly. Yes. Unless there are a lot of pharmaceutical vendors on the line. Okay, I'm being quiet. Go ahead.
Thank you for participating in the poll. Now back to the presenters.
Yeah, for the 58% of you that are unsure, I'm sure. right? Kathy?
Yeah, you need to make sure that you have done this because, again, reporting has started. There are a lot of drugs that you're going to have to provide this information on if it is applicable to your organization. On price transparency, just a little bit about the changes that were included to the machine readable file in the final outpatient rule, and clarification that although the new requirements are effective January 1, the enforcement is delayed until April 1st, April Fool's Day. I have
Your birthday. Sorry, I always have to say that. It's always Kathy's birthday.
Talk about fools, but never mind. One of the things that I want to make sure that you're aware of is that if you have a current machine readable file that perhaps you updated last January, you still have the requirement to update that machine readable file annually. Even if you are not moving forward yet with the new requirements, again, those aren't going to be enforced until April. Make sure that your machine readable file has been updated at least annually. Under the new requirements that would be effective now, but enforced in April, if your payment is based upon a percentage or an algorithm, you're going to have to report your payment rates. I use standard charges here because that is what CMS uses, although charges are payment rates. You're going to have to report at the 10th, median, and 90th percentile for each individual service, for each individual payer for whom you're reimbursed based upon a percentage or an algorithm. You're also going to have to report the code count, the number of accounts that were involved in doing that calculation. Your information related to calculating the 10th, the median, and the 90th would need to come from your remit or an equivalent source of remittance data, essentially your 835 or its equivalent. You must look back at least 12 months, but no longer than 15 months. Obviously, if it's a brand new contract, then you don't have that historical data to report, so you'd be working directly off of your contract. You're also going to have to encode the name of your CEO, president, or senior official who is responsible for the overseeing of this information. You're going to have to identify your national provider identifier, including the taxonomy code as to whether you are a hospital or a hospital unit. And there is a modified attestation, basically saying that you have met the requirements of reporting the 10th, the median, and 90th percentile in your file. Along with the issue of hospital price transparency, we also received a proposed rule related to transparency in coverage. This relates to the requirements for posting pricing information, negotiated rate information on the part of payers. Comments on this proposed rule are due on February 21st, but what they are essentially working to do is to make the transparency and coverage data easier to use and more accurate and more standardized. Some key areas that we are looking at is that they would be required to exclude data for those providers that are not going to provide a particular service. In other words, a cardiologist does not tend to provide plastic surgery. Therefore, those services would not be reported under a cardiologist data. They're revising the timeframes for reporting from monthly to quarterly, and that the files themselves would be organized by provider network rather by individual plan or policy. They're changing the way that the data will be reported for out-of-network pricing. And interesting, because if you've tried to take a look at the payer files, they're massive, but they have indicated that the insurers would be required to make the same level of detail available online, in print, or by phone. So this could be massive on the part of payers and what they're going to have to report. So with that, I think we have another polling question.
All right, our fourth question is, will your hospital be able to comply with the new machine readable file requirements by the April 1st enforcement date? Yes, no, I don't know, or I'm not associated with a hospital.
And remember, for purposes of price transparency, a critical access hospital is a hospital, as is a rural
Absolutely.
emergency hospital.
Absolutely.
They do have to post. These rules are applicable. Like, how many definitions of hospital can we have, Kathy?
I don't know.
Crazy.
That comes on January 27th, that other program we're doing.
That's right.
All right, thank you for participating in the poll. Now back to the presenters.
Oh, let's see the results.
Results, there we go.
Yes,
Excellent.
that's what we want to see.
And I like that. No, at less than 1%. That's excellent. Good work there.
Absolutely.
Okay. Alternative payment models. CMS told us they were restructuring the strategic vision for their alternative payment models, testing alternative payment models early in the year. And the last part of the year, they were pushing them out at an incredible rate. These new a new set of acronyms, as you can see from the lead title of the slide. It's all about the acronym. But you see that these models that they've announced go really across administrative priorities, from enhancing program integrity with the WISER model, which is prior authorization in traditional Medicare, expanding that, reducing drug costs. We have 4 different models there intended to reduce drug costs in Medicare.
I love generous.
Generous, guard, glow, and balance. It's like the happy words that become programs, right? Testing lifestyle and functional medicine interventions, MAHA Elevate, which is actually narrower in scope, the number of states they're going to test that in. My personal favorite, the access model, which is outcome-based payment for managing chronic conditions, replacing ACO REACH now with LEAD model, and engaging specialists through mandatory payment models. That would be TEAM, which started January 1st, and the ambulatory specialty model, which starts January 1st, 2027. Briefly, let's go talk about these. As I said, Access is my favorite. It is the one that they released the request for application on December 19th. The applications are due for April 1. Don't worry, they're going to have an application cycle each year. So this is not closing off the opportunity. But you could read the detail on this slide, but let me see if I can explain this without looking at the bullet points. Part B providers, you have to be an enrolled Part B provider to apply for the program, but those Part B providers are going to receive outcome-aligned payments, or OAPs, for those beneficiaries for whom they provide these management services. And as you see, it's not all Medicare beneficiaries. You have to be diagnosed with one of those conditions that's listed under 4 tracks. But that Part B entity is then responsible for providing care management services, utilizing new technologies and delivery of those services and the like. Their final payment rate will depend on actual outcomes for the beneficiaries for whom they're providing those management services. What makes this really interesting is that now these Part B providers deliver a service to another physician's patient, right? Patient has a different primary care provider. They forward that information to the primary care provider. That is an opportunity for the primary care provider to bill for a separate service, a coordination service, and that reimbursement setting at $30. So obviously an incentive for primary care physicians to enroll their beneficiaries with one of these Part B access providers or provide the service directly themselves. There are obviously some hiccups in this process because we can expect how the marketing of this program will go, how our patients are going to be recruited. Of course, they're going to have to consent, but you can only, of course, be in one access program at a time. How will you go through the enrollment process? We'll just have to see how that practically works out. And then also this open season list of technologies. CMS intends to maintain a list of technologies, not any type of endorsement, but merely sort of a posting of technologies that can be used in the delivery of access type services. So it's a very interesting approach to kind of changing care management, outsourcing care management for smaller practices, but again, incentivizing that it be real care management because they're then accountable for the actual outcomes. The long-term ACO, the lead model, the replacement for ACO REACH, has some really important enhancements to that ACO REACH model, particularly focused around how they're going to do benchmarking with the intent of encouraging broader participation, especially for rural providers. So addressing the issue of the higher COV rates, the higher swing bed rates, the higher RHC rates. We shouldn't be penalizing your participation because we simply pay you enough to cover your costs. And so these benchmarks are included to address that issue and unfairness in the shared savings type model. There's also new episode-based risk arrangements between ACOs and preferred providers, so trying to bring specialists into the participation with incentive payments made by their ACOs. Finally, getting these specialists involved through traditional Medicare mandatory APMs. You should be familiar with TEAM, which is the episodic payment around surgical procedures and the hospitals being accountable for the total cost of care across 30 days, which we know is leading to pressure on post-acute services, particularly patients in swing beds versus SNFs. We'll see how that issue is going to play out now that we are live with TEAM. And then ambulatory surgery model, ambulatory specialty model, that goes live next year. It's sort of a super MIPS is how I think of it, because docs that provide services for patients with heart failure or with lower back pain, they are going to be required to report on a limited set of measures, and they'll be scored in comparison to all other physicians that are in the same category as they are. Now, again, it's not all orthopods and neurosurgeons or neurologists. It's only going to be about 25% of selected CBSAs. But that universe of docs, there literally is going to be number 1 through number 12,000, and they will receive an adjustment on all of their fee schedule payments based on their score. So not just the payments related to these particular patients, but all of their patients across the score. And I tend to think this may be where we see MIPS heading in the next few years, so worth paying attention to. Kathy, Medicare Advantage, take us home. Can't hear you. You're on mute.
They were blowing the leaves out there, so I apologize. We can't do a webinar without talking about Medicare Advantage, so let's do it. Let's wrap up with that, and there is one more polling question coming, folks. On November 25th, CMS did publish the 2027 technical changes proposed rule as it relates to Medicare Advantage. This proposed rule comment period expires January 26th, which is coming very quickly. I wanted to raise this issue on this slide, on this presentation, because of some changes that they have proposed to make to reform the star measures, the quality measures, calculations and reporting functions as it relates to Medicare Advantage plans. They are looking to remove what they say are process heavy or administrative measures. They want to focus on outcomes. The consumer perspective, I guess I would say, yes, outcomes are very important, and to know that. But it also, what they're taking away in terms of those process heavy or administrative measures are things like appeals timeliness. How quickly are they responding to an appeal? Do they have call center support? What type of complaints, both from providers and patients, is the plan receiving? Is their plan finder, is the plan finder accurate? Maximus, forgive that typo, but Maximus, the concurrence rate. When they deny something, does Maximus agree with that decision? Services like eye exams for diabetic patients, statin therapy, etc., and even the issue of how many members are leaving the plan. Those they would be looking to eliminate. So I guess my concern on this, and where I think it is worthy of comment, is that eliminating these particular measures would weaken both the provider and the patient's ability to influence plan behavior. And in addition, it seems to me to weaken oversight and accountability. And those are the things that I think we really need to focus on as it relates to Medicare Advantage. So, as a provider, I urge you to think about commenting on that particular that particular section of the rule. On the issue of complaints, they are continuing the complaint tracking module as it relates to Medicare Advantage plans, and they have actually made this easier to deal with. There is now an online complaint tool that will capture basic information about who's complaining, about the beneficiary, the provider, what plan, etc. And CMS is going to review those complaints, put them in a queue, and triage the work that needs to be done. I've given you on the slide the link to that complaint form. And with that, I think we have one more slide deck.
Okay, our fifth and final question is.
And I apologize, Jennifer, slide deck versus polling question. Sorry.
Not a problem. So our fifth poll is, has your organization used the provider complaint process as it relates to Medicare Advantage plans? Yes, no, I don't know, or I'm not associated with a hospital. Thank you for participating in our poll. Back to the presenters.
And to the 16% who says yes, thank you, thank you, thank you.
Well, amazing. We are stopping on time, Kathy. It may be a first. I think this is our New Year's resolution, doing the webinars on time. But thank you all for joining us. We'll see you back for LGR later this year, and have a great rest of your day. Jennifer, back to you.
Thanks to our presenters, Martie and Kathy. Also, the slides and recordings for every episode of PYA's webinar series are in the Thought Leadership section of PYA's website, pyapc.com. While at our website, you may register for other PYA webinars and learn more about the full range of services offered by PYA. On behalf of PYA, thank you for joining us. Have a great rest of your day.